You're listening to This Week in Cardiology from theheart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.
You can now access the latest in medical news on your Amazon Alexa-enabled device. Join me, Perry Wilson, every weekday morning for Medscape Medical Minute, where I highlight the top medical stories of the day. To add Medscape Medical Minute to your flash briefing, search for Medscape Medical Minute on Amazon and click Enable. Or open the Amazon Alexa app, go to Skills, search for Medscape Medical Minute, and click Enable. Then say, Alexa, what's the news? Or Alexa, what's my flash briefing? I hope you'll join us.
Hi, everyone. This is John Mandrola from theheart.org, Medscape Cardiology, and this is This Week in Cardiology for December 20th, 2024. This week, I have some strong listener feedback, multiple studies in AF ablation, a Danish trial substudy of ICDs and non-ischemic cardiomyopathy, and more data on eye complications of GLP-1 agonist. The first thing to say, as always, is I'm grateful for the year we had. I really appreciate the support. I get many notes, and I see people at conferences who listen to the podcast, and it's just very nice, and thank you. Secondly, as always, we take the next 2 weeks off for the holidays. I will see you back in the first week of January. The good news is that This Week in Cardiology has been extended another year. Okay, listener feedback, CCTA feedback. I received perhaps my strongest rebuttal this week regarding my negative views of CCTA. Now, I've published on the CCTA with Andrew Foy in JAMA Internal Medicine, and I'll link to our meta-analysis that looked at trials comparing CCTA versus functional testing in patients who presented with suspected disease, mostly chest pain. Our main finding was that CCTA relative to functional testing increased the diagnosis of CAD, increased angiography and PCI, and had minimal reduction of outcomes. In fact, we would have found no reduction in any outcomes if we were allowed to exclude the Scott-Hart trial. But we were forced to include the Scott-Hart trial by reviewers. The reason why we felt that Scott-Hart did not belong in our meta-analysis is because 85% of patients in that trial had both functional testing and CCTA, so Scott-Hart was not really a comparison of functional testing and CCTA. My concern about coronary CTA use in the U.S. is that it causes massive overdiagnosis and overuse of revascularization, which of course we know does not reduce hard clinical outcomes. And hospitals in the U.S. are rushing to put in CCTA machines because they know it is like a cash machine. Because as soon as American doctors see disease, boom, it starts the cascade of ischemia testing, angiography, PCI, and even CABG. But this appears to be an American phenomenon. I received a strong rebuttal from Professor Bjarne Lind Norgard, I probably pronounced that wrong, who is a professor at the Aarhus University Hospital in Denmark. He admonished me, as did my mentor, Dr. William Miles, that a test or procedure is almost never the problem. The problem instead is its misuse by humans. Now, I'll tell you parts of what Professor Norgard sent me, and keep in mind that as you hear this, recall that Denmark has a public health system, and doctors are paid salaries that do not depend on the number of procedures they do. So Norgard says, John, in Denmark, CTA has been the preferred test in patients with de novo symptoms suggestive of CAD over the past more than 10 years. He goes on, in Denmark, referral to CTA is based on a patient face-to-face consultation. The CTA is performed by experienced cardiologist and dedicated text. Decision-making after CTA, i.e. downstream management, no treatment, testing, OMT, cath, or OMT, is based on the CTA results, anatomy risk, plaque burden, morphology, stenosis, taking into account also the patient risk profile, patient symptoms, and treatment. In other words, there's a total decision being made, not a reflex, disease equals catheterization. Following implementation of the CTA testing in Denmark as a first-line test, which has now plateaued on approximately 10,000 scans, we have since 2015 seen get this, sit down for this, a 33% decline in the use of invasive catheterization and a 14% reduction in PCIs. And Norgaard speculates that this may, of course, be driven by the results from landmark trials like Courage and Berry 2T and Ischemia and Revive BCIS, which unambiguously show the value of medical therapy relative to revascularization in stable disease. He goes on and says that in 2023 at Aarhus University Hospital, which has the largest CTA production in Western Denmark, they performed 1,400 CTAs, despite the fact that 75% were diagnosed with CAD, including 24% with significant disease. Only 13% were referred to cath, and of those, only 2/3 underwent revascularization. Norgaard writes that he often sees patients with severe three-vessel or diffuse disease without left main involvement and only mild symptoms, not yet on optimal medical therapy, and in the majority of such cases, we simply recommend a medical therapy strategy. We talk to the patient again in 2 months. If the patient is well without side effects on medical therapy, we stick with the medicines, while in the event of continuing or worse symptoms, we take into account the patient preference. We'll then refer to cath. This is a safe strategy in a cohort of stable CAD patients. Norgaard concludes by saying these experiences from Denmark clearly show that the benefit or harm by CTA should be viewed in context of the healthcare organization in which it is applied. CTA, he believes, is the best first-line test in symptomatic patients, providing important information on whether there is disease or not, on the CAD phenotype, and as a guidance for revascularization procedure in the few patients needing this. That is in the right hands and in the right organization. My gosh. In fact, I knew this. Of course I knew this, but I had been overwhelmed with the overuse of imaging and its downstream testing here in the U.S. that I had forgotten what the PI of the Dankavas trial, Dr. Axel Didriksen, had told me when I met him. He told me about their experience with coronary artery calcium imaging as part of their study screening program. Professor Didriksen said that there was not a worry to find coronary calcium because in Denmark this would not lead to a cascade of ischemia testing. It would lead to medical therapy. I want to say thanks to my Danish friends for reminding me that there are parts of the world that practice evidence-based medicine, perhaps because Danes are smarter, but perhaps because Danes have better aligned incentives. All right, second listener feedback is on my negative take of the option trial, and I'm going to link to both my written and spoken words. But briefly, the trial compared stroke and bleeding endpoints in patients who had AF ablation plus a DOAC or AF ablation plus a concomitant left atrial appendage occlusion. The non-inferiority trial delivered positive results. Non-inferiority was met for the efficacy endpoint and superiority for reduction in bleeding in the LA appendage closure arm. But it was one of the most flawed trials I have reported in the last 10 years. I wrote a post before the results were published chronicling the flaws and how these flaws would lead to positive results. And indeed, it was exactly as I predicted. This week, I received 2 messages about improving critical appraisal in trainees based really on the option trial. One came from a senior program director, and the other from a young doctor who had just joined an academic program, and I'll summarize the latter's words to me. The young academic said, "I appreciated your take on the option trial. Surely enough, we had a journal club this week from one of our trainees who touted that we have now an option that is not inferior to leaving the left atrial appendage alone when ablation is offered." Sure enough, everyone on this virtual journal club meeting call applauded the science, the presentation, without inquiry, and then signed off. This doctor's question to me was, how do I suggest comfortably pushing back on this unabashed enthusiasm for these discussions? I agree with your take about non-inferiority and endpoint selection for the option trial, he wrote. However, it is hard to convince a large audience of impressionable trainees to think beyond the abstract conclusion. Do you have any suggestions? And so I stewed about this for a few days, hoping to come up with an easy, actionable answer like, do this, do that. I even reached out to others in academia. And I actually don't have a simple solution, and here is my best effort. First, you have to question the presenter on basic methodology. In journal clubs, we have to have presenters get asked about methodology. For instance, what was the effect of adding death to a composite endpoint of a non-inferiority trial when we already know that death will not be affected by either treatment? In the option trial, we knew that death would not be affected because we had LAOS 3 where stroke was reduced, but it was not enough to change death rates. Second thing is, as it is with publications, I think that every journal club should have a serious section on limitations. These should be robust discussions of limitations, not because we're trying to be negative about studies, but because it's critical for evidence translation. Third, I think the only way to affect impressionable trainees is to foster a culture of skepticism without cynicism. I would have journal clubs on classic trials such as the CAST and Women's Health Initiative so trainees can at least learn the concept of medical reversals. During the pandemic, I sat in journal clubs at Penn State, and I think Andrew Foy actually had successfully created a skeptical group. Then these trainees go on to other programs and they teach others the same culture of skepticism without cynicism. And actually, this is the goal of this podcast, to give permission for skepticism, but to not be cynical and to know that we do a lot of good for patients. All right, first topic is there was a number of AF ablation trials. In fact, another listener called me out this week for missing 2 ablation trials from the American Heart Association. But I wrote back with a smiley face and said that I didn't really miss them, I just wasn't very impressed. But we should talk about this because there are kind of bigger concepts. JAMA published the PROMPT AF trial, which was a randomized comparison of PVI alone or PVI plus optimized linear ablation aided by infusion of alcohol into the vein of Marshall in patients with persistent AF. Now, the clinical relevance here is that patients with persistent AFib have worse outcomes after ablation compared with patients with paroxysmal AF in general. The largest trial, called STAR-AF2 in persistent AFib, found that PVI alone yielded similar results to PVI plus ablation of complex electrograms or PVI plus linear ablation. And really, for persistent AFib, only 2 trials have shown slightly improved efficacy of additional ablation beyond just pulmonary vein isolation alone. One trial was the CONVERGE trial of combined RF ablation and surgical ablation, and the other trial was called the VENUS trial, wherein alcohol infusion into the vein of Marshall was used. In VENUS, both PVI and PVI plus vein of Marshall groups had tons of ablation outside the PV, so it's hard to sort out. The groups with the vein of Marshall, alcohol infusion had significantly better freedom from AF. The primary endpoint was like 49% versus 38%, but it was really close p-value of 0.04. Now, a word on alcohol infusion into the vein of Marshall. This is doable. I have done it, so if I can do it, it's pretty doable. But it's labor intensive unless you do it all the time. You have to have contrast, guiding catheters, PCI wires, and balloons, and you have to have a high-quality X-ray system. The vein of Marshall is variable, and it's not always there. And if you can do it, though, the degree of destruction along the mitral isthmus and anterior ridge of the left-sided PVs is substantial. The destruction can even extend to the roof and parts of the posterior wall. So when done, and in some centers when it's done routinely, it definitely aids pulmonary vein isolation because it does a lot of the ablation with the alcohol. Okay, the PROMPT AF trial was a cleaner trial than VENUS. What I mean is the control group had PVI alone. That is it. The active arm got alcohol infusion of the vein of Marshall, and that was to assist linear lesions, which mostly included the mitral isthmus, but also the left atrial roof and the cavo tricuspid isthmus in the right atrium. The primary endpoint was freedom from AF without antiarrhythmic drugs at 1 year. They had about 500 patients, so more than venous. At 1 year, 71% had freedom from AF in the linear ablation group with alcohol versus 61.5% in the PVI alone group. The hazard ratio was 0.73, and get this, the confidence intervals went from 0.54 to 0.99, and the p-value was 0.045. Notable was that 7 patients assigned to the intervention group, the alcohol group, had pericarditis or pericardial effusion, compared with none in the PVI alone group. So my comments. I really like this. This is a nice effort. This is what we should be doing when we think we have a technique that's better than the other. I say good on the investigators from multiple centers in China. They randomized 2 ablation strategies, and this is the way forward. Now, my interpretation of the trial, though, is that linear ablation with alcohol into the vein of Marshall is a lot of work for very little gain. The recurrence rate of 30% versus 40%, that seems hardly clinically meaningful to me. There are also 7 pericardial events with the extra ablation. That said, I have to say that the vein of Marshall alcohol ablation is a very nice trick. It's useful for ablating the mitral isthmus to eliminate perimitral flutter. And if you don't practice it, it's hard to be good at it. And I can tell you that there are mitral isthmuses that I was not able to do with ablation, either epicardial or endocardial, and the vein of Marshall ablation is what worked. So my recommendation is to learn the technique, but prompt AF does not convince me to adapt it for a normal workflow. Interesting also was that no subgroup, even those with more advanced LA disease, did not seem to benefit more from the extra ablation, which is interesting because PVI alone in more advanced disease performed quite well, as it did in the STAR AF2 trial. Now, the other thing to note is that pulse field ablation is set to transform LA ablation for AFib. PFA is going to potentially allow us to do more durable PVI, I hope, and also more durable posterior wall isolation, which will also, if you do posterior wall, you have a roof line. My final summarizing point on AF ablation, and this is something for everyone, not just EPs, but it's a variant of something I have said many times. Now, here's the point. PVI can be amazing for patients who have minimal atrial disease, who have focal drivers from the PVs. In this case, it's almost a curative procedure. But for the vast majority of patients with AF who come by AF by having cardiometabolic risk factors, who have atrial structural or electrical disease, or said another way, people whose AFib stems from scar, it is unlikely that creating more scar will be a disease-modifying treatment. I believe the next major advance in AF will not be a better way to kill heart cells with a catheter, but a better understanding of what actually causes AFib. All right, now the AHA also featured a trial called CRRF-PeAF from multiple centers in Japan. This was a comparison of cryoballoon versus RF ablation in patients with persistent AF. Recall that the very important Fire and Ice trial was RF versus cryoballoon in patients with PAF, and there was absolutely no difference between the 2 techniques. Well, the CRRF persistent AF study also found no difference in freedom from AF with either of the 2 technologies. But in this trial, both arms had oodles of ablation outside of PV isolation, so it's kind of hard to sort out the true PVI effects. The paper's not published yet, and I can say more when it's published, but again, I emphasize that the answer to persistent AFib is unlikely to come from one or another ablation strategy. Finally, a note on SVC isolation during AFib ablation. Circulation, Arrhythmia, and Electrophysiology published a small RCT from Spanish centers called the CAVAC trial, C-A-V-A-C. This was a PVI alone with a cryoballoon versus PVI plus SVC isolation with a cryoballoon. The idea being that the SVC can be like a pulmonary vein and can have focal drivers. The freedom from AF was no different in both groups, but get this, 1 in 5 patients in the SVC isolation arm ended up with phrenic nerve paralysis and sinus node dysfunction. Fortunately, all but one of the phrenic nerve injuries was transient and no sinus node injury required pacing. Obviously, doing SVC isolation with a cryoballoon is hazardous due to the close proximity of the phrenic nerve. SVC isolation, though, as an adjunct, should probably be tested formally with PFA, since electrical energy does not seem to harm the phrenic nerve as much, as there's actually some phrenic nerve injury in the Advent trial that was always transient. But again, I'm not a big fan of SVC isolation. I tried it back in the day with RF and never found it to be very successful. And there are some important structures there that you don't want to harm, like the phrenic nerve and the sinus node. All right, next topic is a Danish trial substudy. In talks with patients about the ICD decision, often this is CRTP versus CRTD, I mentioned the Danish trial. 2016, New England Journal of Medicine, ICD versus medical therapy in 556 patients with non-ischemic cardiomyopathy. The median LV ejection fraction in this trial, 25%, and after nearly 6 years of follow-up, there was no difference in mortality, none. Background therapy was excellent. One of the most controversial aspects of cardiology, in my opinion, is how little this Danish trial has influenced care, at least here in the U.S. Even though there was a provocative subgroup analysis which showed a strong heterogeneous treatment effect based on age, where younger patients in Danish benefited and older patients trended toward harm. While the age-related heterogeneous treatment effect made sense, it is still a subgroup analysis within a non-significant trial. This month, the authors of the Danish trial have published in circulation as a research letter a post-hoc study looking at the LVEF and the ICD in non-ischemic cardiomyopathy. The authors write, quote, "There are no detailed reports on the efficacy of ICD implantation according to LVEF in patients with HFrEF. So they examine the effects of the primary prevention ICD according to the EF in Danish." Now, before I tell you the results, I want to push back a little on the notion that there are no detailed reports on the efficacy of the ICD according to the LVEF. I think there actually are some reports. I would point here to both the SCUDHEF and MADE-IT2 authors have published subgroup analyses showing that most of the ICD benefit in these trials were in patients with the lower ejection fractions. And I'll link to these. Now, in this substudy, in the Danish substudy, the authors explored 3 different associations. Now, note I said associations because this is basically an observational analysis of an RCT. The first association is the effect of the ICD versus usual care according to continuous EF. The second is the ICD effect according to EF in each age category less than 70 or greater than 70. And the third is the ICD effect according to CRT use or non-use. So the first finding is that there was no significant interaction between the EF examined as a continuous variable. Here you have to think of a graph with LVEF on the x-axis and the hazard ratio on the y-axis and then splines. Basically, the ICD effects remain flat at about 1.0, no matter the EF, from 10% to 35%. There was also no significant interaction between EF and CV death or sudden death, though there was a trend towards better ICD effect for sudden death prevention at better ejection fractions, which makes sense, right? Because at lower ejection fractions, patients are more likely to die of pump failure rather than arrhythmic death. Now let's go to the age categories in LVEF. But first, before I say anything, remember that in the non-significant overall Danish study, there was ICD benefit in young people and a trend toward harm in older people. The question now is, was that modified by ejection fraction? And the first answer was no. In patients less than 70, the left ventricular ejection fraction did not significantly modify the ICD benefit for mortality, CV death, or sudden cardiac death. However, in older patients, there was a positive P for interaction based on the left ventricular ejection fraction. That is, for older patients, there was a hazard ratio point estimate around 3.0 for the lowest EF. That is, the ICD is harmful relative to usual care in older patients with a bad ventricle. But as the ejection fraction got better in older patients, the ICD turned towards benefit. The weird thing, though, was that the absolute difference was 54% versus 56%, and this absolute difference of only 2% was less than all other categories. I think that this age-related LVEF finding makes sense, right? If you believe the main trial heterogeneous treatment effects, that is, younger patients with non-ischemic cardiomyopathy tend to do better with an ICD, while older patients trend toward harm, you'd also expect older patients with the lowest EF to be most likely to incur harm from the device because their mode of death is going to be pump failure or some other competing cause of death. Now, the final finding is that in patients with and without a CRT, the LVEF did not significantly modify the ICD effect. The authors add the appropriate caveat that these findings should be considered as hypothesis generating. They also note other limitations include a lack of generalizability to all patients with HFrEF and a lack of a central adjudication of LVEF measurements, which were investigated reported. But they write, in conclusion, in patients less than 70 years, LVEF did not significantly modify the, quote, beneficial effect of ICD implantation. However, in patients older than 70, those with a higher but not lower LVEF benefited from ICD implantation. This latter finding supports the notion that patients with a lower LVEF, especially those over 70 years, are more likely to die from pump failure or terminal heart failure, and therefore less likely to derive benefit from an ICD. Now, my comments. Wow. Danish, I believe, is one of the most important trials in modern cardiology. It proved Rod Tung, Peter Zimmetbaum, and Mark Josephson correct in their famous critical appraisal paper published in 2008 in JACC, where they argued that ICD benefit in non-ischemic cardiomyopathy patients should be questioned. Indeed, they were correct. The problem with Danish is not the trial, but our interpretation of it. The trial showed not a hint of mortality benefit from the ICD in general overall. In my opinion, it should have changed guidelines. Instead, it was just added to meta-analyses of 20-year-old trials and the benefit remained. But this is misguided. The ICD did not provide an average benefit in Danish because background therapy was so good, and it is even better now, 10 years from when Danish was recruiting patients. Proponents of the ICD use this data both ways, right? If you have a young person with non-ischemic cardiomyopathy, then the proponent will cite the subgroup analysis, which I admit is compelling, but it's still a subgroup analysis from a non-significant trial. Subgroup analysis, in my opinion, should be used not for clinical decisions, but rather to plan future trials. If you want to use subgroups to make clinical decisions, then I'm afraid you're going to have to accept astrological sign as a modifier of aspirin benefit in acute myocardial infarction. Proponents of the ICD can also dismiss the Danish data when they want to implant an ICD in an older patient with non-ischemic cardiomyopathy because they can just say the meta-analyses are positive. And my patient, of course, they'll say, isn't able to take such great background therapy, so they'll benefit from the ICD. So, in sum, while the findings of this association study make sense, I don't like the author's conclusion with words like, in the less than 70 years age group, LVEF did not modify the beneficial effect of the ICD. That's not what Danish found. I believe that this post-hoc study overcalls its own precision, for if we argue that subgroups deserve our caution, subgroups of subgroups should deserve even more caution. All right, final topic today, and I know I've gone on for a while, but this was eye diseases and GLP-1 agonists. And in July, I covered a methodologically weak study published in JAMA Ophthalmology in which the authors associated semaglutide use with a rare but serious eye condition called non-arteritic anterior ischemic optic neuropathy, or NAION, or I guess it's NAION. The JAMA Ophthalmology article in the summer blew up with media coverage, but it was a really weak study marred by surveillance bias, collider bias, all kinds of bias. Now, I had just been to Denmark and visited with researchers who had showed me the basics of how they use their national registry. It's pretty amazing. So after that study came out, I sent my friend Soren Didriksen an email, and I just thought that the Danish registry might be a good way to explore this association. And Soren emailed me back that, in fact, some of his colleagues were interested in this, and now there's 2 studies out using the Danish registry. One is a really weak and simply identified all persons with type 2 diabetes and was stratified by use or non-use of semaglutide. In that paper, semaglutide exposure was associated with a higher incidence rate. It was like 0.228 versus 0.09 per 1,000 person years, and it was independently predicted a higher risk of oncoming eye disease. Hazard ratio was 2.19. Now, this paper made adjustments, but was a pretty weak paper, and this could clearly have been that sicker patients were getting semaglutide versus not getting semaglutide. A doctor named Anton Poudegard led a more rigorous analysis, and I'll link to it. Their paper is published as a preprint. They did a binational, Denmark and Norway, active comparator new user cohort study with propensity matching to adjust for confounding. They also did a fixed effect meta-analysis and a supplementary self-controlled analysis like a symmetry analysis, where 1 year before, 1 year after. Their main outcome was going to be incidence rates of the non-arteritic optic neuropathy among semaglutide and SGLT2 inhibitor users, along with hazard ratio and incident rate differences with confidence intervals. Estimates from Denmark and Norway were pooled using a fixed effects model, and the supplementary self-controlled study, which is a cool thing where they look at rates of the eye disease 1 year before and 1 year after semaglutide exposure. It outputs this thing called a symmetry ratio, and if there's no effect, it ought to be 1.0. So first they found 45,000 eligible users of semaglutide for type 2 diabetes in Denmark and 17,000 in Norway. Of course, they can find these things because they have a national registry. They then observed 32 cases of the eye disease events among semaglutide users, 24 in Denmark and 8 in Norway. So these yielded an unadjusted incidence of 2.2 per 10,000 years among Danish semaglutide initiators. They then compared that to SGLT2 inhibitor initiators and found an unadjusted incidence rate of 1.2 per 10,000. The corresponding unadjusted incidence rates in Norway were 2.9 and 0.92. And so after adjustment, they found a pooled hazard ratio of 2.81. The confidence intervals were wide, going from 1.6 to 4.7, and the risk difference of plus 1.41 per 10,000 person years. They also found that the results were consistent across sensitivity and supplementary analysis, and they found a notably stronger association in a post hoc per protocol analysis. Here, the hazard ratio was up to 6.35, but again, because the per protocol analysis had fewer events, the confidence intervals are wider at 2.8 and 14.0. And in the supplementary self-controlled study, the symmetry ratios for the eye disease were 1.14, confidence interval 0.55 to 2.3 in Denmark, and 2.67 in Norway, with confidence intervals going from 0.91 to 8.9. And I think both of these are going to be considered non-significant because the symmetry ratio actually dips below 1. The authors concluded that these findings, quote, support an association between the use of semaglutide for type 2 diabetes and the risk of non-arteritic optic neuropathy with a more than twofold increased hazard ratio. However, the absolute risk of the eye disease remains low among semaglutide users. An analysis of an association between semaglutide for obesity and non-arteritic optic neuropathy were inconclusive. So my comments, the latter study is clearly stronger. The comparison of using GLP drugs and SGLT users is clever. It doesn't make it a random comparison, but it does do a decent job of making baseline characteristics similar because the choice of the two drugs are similar in diabetic patients. Now, it's also possible that since GLP-1 drugs make patients get fewer cardiovascular events, they may live longer and be exposed longer and have other events like the eye issue. Nonetheless, if this risk is real, it is very low in absolute terms. You're talking about 1% risk difference per 10,000, and it must be balanced against the reduction in major cardiovascular outcomes in patients with diabetes, CKD, or obesity. However, I would say that it's going to be notable that millions of people will soon take this class of drugs. So if this risk is not limited to patients with diabetes, it could be important from a public health point of view, and I think we're going to need to do more studies looking at this association. Final comment, keep in mind that such a risk could never be discovered in a randomized controlled trial, and so this is a great use of observational data, and the Danish registry is a national treasure because it's much better for looking at signals like this rather than, say, a single-center ophthalmology clinic. That's it for this week in cardiology in 2024. As always, if you like this podcast, please consider giving us a rating, writing us a review. This helps others find us. It helps me learn. Until next year, this is John Mandrola from the Heart.org, Medscape Cardiology.
You're listening to This Week in Cardiology from the Heart.org, Medscape Cardiology. This podcast is intended for healthcare professionals only. Any views expressed are the presenter's own and do not necessarily reflect the views of WebMD or Medscape.